Hello guys, and welcome to the next installment of Surviving the Mayhem. Now I know I said I was going to do oral topics with you guys, but I just can't resist doing a small piece on Winfocus World Congress that was the 12th and 13th of June. Because I love all things ultrasound, I just like to tell you guys all about it and give you a little bit of my understanding of some of the cool topics. While this is just a tiny little bit, the tip of the iceberg basically, you guys can always go to Winfocus and become an affiliate member. I think for South Africa it's like 30 euros, and then you can watch all the videos from the Congress and see why I'm so excited about it. But let's dive into some of the things that were said. Now, one of the first lectures was about getting the most out of your ultrasound practice, and the lecturer here gave about 10 steps on how to improve your image quality. I think it was really cool because it was kind of like a back to basics thing. Sometimes we need to go back to basics and just learn some of the things. All of it is quite simple, quite basic, but in the end, you have to actually practice it to be able to do it. So what I used to do is take one at a time. And now, especially with the transducer movements, I think when you're teaching somebody ultrasound, as we have to do with as registrars, it's quite nice to be able to have that universal language, to be able to explain to somebody how to move the probe in order to get an image. Then, the other things, starting with the depth, the overall gain, the time gain compensation, those things, I had to kind of take one at a time, work on it, and eventually it became second nature. So with every ultrasound you do, just add a little extra step on these 10 steps, and by the end you should be getting quite good images. I'm also going to start from scratch and go back to basics, as I said, and get my image quality back to perfect again. Well, not always perfect, it depends on the patient. Okay, so that was a pretty cool one. And now next, I'm going to dive into the heart of the matter. That was the title of two of the lectures, one on day 1 and one on day 2. And it's all about the cardiac ultrasound. And since cardiac ultrasound is one of my favorites, I'm going to stand still here for a while. Now, one of the sessions, the first one in the series, was about left ventricular outflow tract, VTI, and how that and the left ventricular outflow diameter can be used to calculate stroke volume. And then, stroke volume or cardiac output is stroke volume times heart rate, so you can get the cardiac output for the patient. Now, it's been shown that looking at the cardiac output, or the left ventricular outflow tract, VTI, is actually a bit more sensitive, a marker for mortality in heart failure patients than the ejection fraction, because you can have a compensated heart failure with a low ejection fraction anyway. So I think this is something we need to start practicing, and it's definitely on my reading list. I don't want to delve too deep into it because I still have to read on it and practice it a little bit. But I think this is the way where we should go, because we can also monitor our therapy by looking at the LVOT VTI and see, if what we're doing is working. We can do serial measurements. And now he, on the lecturer, did it in a parasternal long axis, where he measured both the diameter and the outflow tract VTI. On there, I was taught how to do it on the apical 4 chamber, so that's why I said I still want to read and see how we can apply this. Next was a lecture on tamponade. Now, I thought this was really practical, and from my understanding of this and then the pericardiocentesis lecture, some of the things said there was that tamponade isn't just a big effusion with a heart swimming in it. There's actually a bit of a spectrum, and some conditions that we need to be cognizant of, where we might kind of miss a tamponade if we're not careful. So first things first is what is the first sign of tamponade? Was right atrial systolic collapse. Now, what is systole? What is diastole? It's a pro tip that they gave was that systole is obviously when your mitral valve is closed, diastole is when it's open. So you can just look for that. Now, the nice thing is that most machines you can freeze and scroll back so that you can see that atrial collapse, because it might not be that apparent, especially if the patient has a tachycardia. Then going forward, this is maybe a good way to see an early tamponade, but it's not the most sensitive marker of tamponade. So the most sensitive marker of tamponade would be right ventricular diastolic collapse. So here you're looking at the ventricle and diastole, and you'll clearly see a collapse. And then, it's a bit of a spectrum, so going through to that swinging heart thing. But, you're not always going to see the right side collapse. And here, there's an important condition called pulmonary hypertension, where you have increased right-sided pressures and your right ventricle isn't going to collapse, and you might not see that. So even with an effusion, just be careful with patients with pulmonary hypertension, because they might be in tamponade even though you don't see the signs of it. And then another condition that's quite important is aortic dissection. So Stanford aortic dissection, hemopericardium in tamponade is actually a very important cause of mortality. And you might do a ultrasound now in a patient with a dissection and not see an effusion, but a little while later they may be decompensating and have a huge effusion. Similarly to that, you might do a ultrasound, drain the hemopericardium, and then you can't just sit on this patient and forget about the patient, because that effusion might or will reaccumulate. So you need to be cognizant of that. Another important condition is post-cardiac surgery, but I don't think that's too applicable on us, as these patients are usually in the ward. Then some conditions that might worsen tamponade. Just remember that if you've got a heart that's already struggling to fill due to something like hypovolemia or increased systemic vascular resistance, as in sepsis, or systolic dysfunction, a new AF, then an outside pressure is going to make the tamponade even worse, or you don't need such a big effusion for it to be a significant one. So that's tamponade. The next lecture I really enjoyed because it was about chronicity, so signs of chronic heart disease that you need to look out for in patients. Now, the whole take-home message of this is that you're treating a patient, not an ultrasound, right? So you can have a patient with chronic changes on the heart, whereas the acute problem doesn't fit in with your picture. So you can have a DCMO patient with vomiting and diarrhea that's actually hypovolemic and has low blood pressure due to that. It's not necessarily cardiogenic shock, although the heart might be big, dilated with a low ejection fraction. So just remember that you need to correlate your ultrasound findings with your history and with your patient's current volumes or status. Another example that they gave was a patient with a D-shaped left ventricle, increased right-sided pressures, dilated right heart, and in this case, you're thinking it might be a PE. Are you going to jump to the lytic if this patient has a low blood pressure? But meanwhile, this patient just has COPD with an infection or something like that. So that was the examples that she gave. But the important things are that size matters. So you need to look at the size of the heart, and a pro tip that she gave was that if you are at a depth of less than 15, your heart is definitely normal size. But if you have to look at your heart at a depth of more than 20, then the heart is big. Okay, so that's a sign of chronicity. Then looking at your chambers, usually the right atrium, the left atrium, and the left ventricle, if they are dilated, that's more of a chronic process, whereas the right ventricle can be both acute or chronic. So just look at the other chambers when you see a big right ventricle. Then hypertrophy. Hypertrophy is also something that doesn't happen in a day, so it's definitely a sign of chronic disease. Look for left ventricular hypertrophy, but also right ventricular hypertrophy. So in a dilated right heart that you think might be a PE, just look for that hypertrophy, because that might also give you an idea whether this could be chronic or not. So I thought that was pretty cool to look at. There were quite a few other things regarding the valves you can also look for, but I'm going to be moving on to the next lecture, which was on the second day, and this one I initially thought I wasn't going to listen to because it was about transesophageal echo. Now, transesophageal echo is not something we have available in our setting, so I figured, you know what, I'm not going to tune into this, but I'm so glad I did because it has a bit of a shock and awe value, and I was really surprised at the findings that this lecturer and the author of the study had. So he was doing transesophageal echo to improve CPR quality. That was one of the applications in resuscitation, and what they found was that in more than 50% of their patients, when compressing during CPR, we're actually compressing the left ventricular outflow tract or the aorta and not the left ventricle as we want to. So with CPR, the whole idea is to press on the left ventricle, force the blood out, then allow for recoil so that it fills again, and then repeat that process. And what he said was that most of the time we're just interfering with that, we're just obstructing that whole process by pressing on the place where the blood is supposed to go, so that to me is quite shocking because now I'm worried that are my patients actually dying because they were going to die anyway, or are they dying because my CPR is not effective because I'm pressing on the wrong place? It has actually been shown that the nipple line that we're traditionally taught to put our hands for CPR is not a very good predictor of where the left ventricle is actually going to be. So that makes me a little worried, and I'm hoping that DEE would become available for us so that we can actually check this. Another example that he gave was they were doing mechanical CPR on a patient, and he showed a video where that left ventricle wasn't moving at all, like no movement, and they had to switch to manual CPR, adjust the hand placement, and then only you could see the left ventricle becoming or being compressed. So I think TEE would be a really good option for resuscitation, and maybe we can save more lives if we have that. The next lecture was on agitated saline contrast study. So because we're in the COVID times, I thought this was a nice one to include. So what the author or the lecturer did was, it's all about refractory hypoxia. So a patient that has refractory hypoxia, and here are some of the times when you should think of it, is a patient that might have a right to left shunt. So to check for that, you can do this agitated saline contrast study, and I love the word agitated saline, makes it sound as if it's cross, but it's actually quite cool how they do it. So you take two 10 ml syringes, one 10 ml syringe with 9 ml of saline, and one 10 ml syringe with 1 ml of air. You put that on a 3-way stopcock, open the stopcock so that it's open to both syringes, and then you kind of push the saline into the air and alternate that until there's little micro bubbles that form in the saline. So that is basically the agitated saline. And then what you do is you need like a CVP, and you inject it into the right heart, and you see those bubbles go into the right heart. If you see it on the left side within 3 to 6 cardiac cycles, then that means there's a right to left shunt. If it's more than 6 cardiac cycles, then there's probably a intrapulmonary shunt. The best is to actually see the bubbles cross the septum so that you can be sure there is a right to left shunt, but that's not always possible. So then look at the 3 to 6 cardiac cycles. So that's something that I would actually like to try, but there are some issues. You are injecting some air into the patient and such, so it is something we have to read on and be careful of. But pretty cool, and something that we should think about in our refractory hypoxic patients. Then the next lecture was something that I'm just including because of the panel discussion, which I found quite interesting, and it was about focus versus echo. When is focus just looking at the heart, eyeballing the heart, not really doing a lot of measurements? When is that not enough? When do you actually need an echo? And here there are 3 distinct entities, meaning you have your focus, you have a kind of a goal-orientated or bedside echo, and then the formal cardiology or radiology echo. And at this stage, the non-cardiology, non-radiology faction, meaning emergency medicine, I suppose, we're improving our skills. We're getting better at doing echoes. We're doing the measurements. So one of the things that I think it was a cardiologist said is, are we actually overstepping our bounds when it comes to the echoes? Are we doing more than we're supposed to? And I'd love to hear your opinion on that. What do you think? Are we actually doing too much? Are we overstepping our bounds? Should we be leaving the information to cardiology to get? And I really like the idea of a goal-orientated echo, that we we can actually answer a question. We're looking at the heart to answer a question regarding our patient's condition now, and that I think is beneficial to the patient. So I don't think we are really overstepping our bounds if we do that. And that was quite cool. That's enough for the cardiology part of Winfocus, and I just want to go through a little bit of pulls and cool things that I learned that was extra. And first thing first is the fast. We do a lot of fasts in the emergency department, and fasts on children. We know that traditionally on the right upper quadrant, that's where our fluid will collect first in an adult patient, but in the pediatric population, the most dependent area in the abdomen is actually the pelvis, so that's where we have to look for the fluid. Don't forget to look in the pelvis in the children. And next was also, it was based on the pediatric population, but I think you can actually extrapolate to the adults, was resuscitation using echo. So you can actually also follow an ABCDE approach, where you start with airway, and you can use the probe to check your airway placement. And I don't think that is necessarily applicable in every airway that you do, but we did have a resuscitation just before the Winfocus Congress, where it was in our field hospital in one of the tents. It was difficult, it was noisy, there was so much going on, and it actually took 3 people to listen to the chest just to make sure that the tube was in and it wasn't a right main bronchus intubation. So I think there it would have been quite quick to just put the probe on, see that the tube is in the right place, and then we could have moved on. Also checking for for lung sliding bilaterally, to make sure that the tube is not too deep, especially in peds. You can also incidentally check NG tube placement with the probe. That was also one of the lectures, but not part of this resuscitation one. Then with B, you can check the lungs for COVID-related changes, B lines for barcode signs for a pneumothorax, so there's lots of applications there. And for C, you can do lines. You can actually check intraosseous line placement, which I thought was really nice and practical, because often we get patients that are brought in with EMS that have intraosseous lines that we don't know are they actually in, or we put in an intraosseous line, and it's a little bit of a are you actually giving the drugs in the right place? So it would be nice to be able to confirm that it is actually in by looking at your ultrasound, and that's something that I think I will apply in the future. Then there's a couple of newer things, like the VEXUS and the GUTS protocol that we can also look at, but those are things that are still on my reading list. And then one thing that's very important for me, that's on my to-do list, that I'm going to start practicing, that I'm very excited about, is ultrasound guided nerve blocks. I think that is a widely underutilized pain management strategy that I think could benefit our patients so much, especially in our ED, where there's often a backlog of beds in the wards, and the patients with their femur fractures or radial fractures or whatever are in the ED for more than a day. I think there we could really make a difference to these patients by just giving them the nerve blocks as a pain management strategy. Just one of the things they did say is that if you use nerve blocks below the ankle, like the popliteal nerve blocks, orthopedic surgeons might not like that too much because of compartment syndrome. Might interfere a little bit with the clinical picture there, so just think before you do it, but I do think that it is an important pain management strategy to consider. So that is a few of the pulls from the Winfocus World Congress. I could keep you busy all day if I had to. But you know, I think this is enough for now. If you really want to, you can go and watch the videos. And now hopefully you can understand why I'm so excited about ultrasound at this stage, because it was really cool and I learned so much. And yeah, I hope you guys stay safe. We are in the third wave here in South Africa right now, and it's quite busy. So keep with the PPE and be careful and social distance as always. I hope you survive the MayhEM for another week.